Yes, we are being recorded, everybody. And that will be available on our YouTube channel later on. If everyone could go ahead and in the chat just drop your name, position, and tribal affiliation, tribal organization affiliation, that would be great. If you're interested in getting continuing education unit credits for this, we offer nursing and medical ones, and I will drop a link in the chat a couple times throughout the hour. You have to complete the evaluation survey in order to be able to get the continuing education credit. And I believe that is all I have.
Okay, thank you so much, Emily. We will go ahead and get started with Amani Rainsby, who gives the update for the Nashville area. Amani, if you want to share your screen.
Thank you, Brian. So welcome everyone and happy Friday. Thanks for joining us for our March COVID-19 Echo session. Today, I will be providing my usual update on COVID-19 epidemiology in the Nashville area or USET region. And so that will just consist of taking a look at some of the graphs and figures that are currently included in our COVID-19 USET area aggregate reports. As most are aware, these reports do focus on COVID-19 cases and vaccinations. At this time, the surveillance reports are sent out on a weekly basis every Wednesday to representatives of USET member tribal nations, including tribal leadership and health directors, as well as our USET staff. And tribal nations also do receive a tribe-specific report alongside that, which does allow you to kind of look more closely at COVID-19 in and around your community specifically. Information specific to tribes is also included in those reports if it is available. Everyone should have received their most recent COVID-19 surveillance reports this past Wednesday, the 9th. Although I do want to mention that in next week's send of the reports, we will be asking whether you would like for us to continue issuing the reports on a weekly basis, or if you would prefer to receive them on a monthly basis. Cases have gone down and remained pretty low in recent times, and so some may feel that a monthly report will suffice. So please be on the lookout for that in next week's reports. As always, please note that the reports can be modified to better meet the needs of your tribal nation as you see fit. And we do hope that you have found their surveillance reports to be helpful in addressing COVID-19 in your community this far. So on this first slide here, we are looking at COVID-19 testing data for the USET region or Nashville area in particular. We have listed the number of new positive test results, the cumulative total of positive test results, as well as a 7-day positivity rate or percent positivity. And this is for the current report week of March 1st to March 8th. And so I mentioned before, this information was taken from this past Wednesday's USET report, although do note that these numbers are showing Tuesday data, as that is when we go to pull it, and then the reports are sent out on Wednesdays. So for this current report week, the number of positive COVID-19 tests at reporting facilities in the IHS Nashville area in the last week was 46, while the cumulative total of positive COVID-19 tests was 16,386, and the 7-day positivity rate at 6.6%. So when referencing some of the numbers reported at the time of our last echo, which was February 11th, and then comparing that to what we're seeing now, it does look like we have seen a notable decrease in the number of new positive COVID-19 test results. We were at 433 cases last month. And so for this week, we were at 46. So that is really great to see that we have continued on the decline. When comparing our cumulative positive results, we were at 15,953 according to our February 9th USET report, and that number has gone up by about 433, which is a lot less of an increase than what we saw for the January to February period, where we saw an increase of about 3,000 positive test results. So again, both data points really show us that things have slowed down and we are definitely seeing less cases of COVID-19 as a whole. The percent positivity rate is a stat that we have used very early in the pandemic, primarily because it does a pretty good job of outlining just how many positive results we are seeing. As we know that increases in the overall number of positive test results is associated with a higher percentage, and then decreases in the percent likely suggest the presence of more negative test results. So when looking at our percent positivity rate from last month, we were at 23.1%, and that percent has since decreased. And I am happy to report that we were at 6.6% this week. So we did go down by 16.5%, which is also indicative again of cases falling since last month. And it also does appear that we had our largest decrease as an area over the last month as well, which we will see more on subsequent slides. So moving on to this next graph and taking a closer look now, we have the number of new positive COVID-19 test results per week with a 12-week retrospective timeframe available to view as well. When looking at the graph, you can see where we started to see an increase in cases due to Omicron around last December, where we were at 295 cases, and then cases very obviously did increase greatly until we peaked at 996 new positive test results. Since then, we have been on a decline, and it does appear, like I said, that we saw our largest decrease in cases from the beginning of February to mid-February. The number of new test results decreased by 294. So there was a pretty big decline during that time compared to more recently, where yes, we are still seeing a decrease, but not as rapid. So this slide displayed shows you the rate of new COVID-19 cases per 10,000 broken out by USET counties or purchase and referred care delivery areas, USET states, and then the United States. There's also a 12-week time frame available for this information, so you can kind of look back at cases over time. Do please note that the data featured on this slide is specifically obtained from CDC and state health departments, and so it is not limited specifically to tribal citizens. Whereas the information that I went over on the past couple of slides was retrieved from IHS. But although this information is not limited to tribal citizens, it has continued to be a pretty good source for gaining insight into how the USET region is being impacted by the pandemic over time. So we have continued to use that. And so with this graph, we can look at rates locally at the county level by USET states, and lastly at a national level, and use those data points to guide COVID-19 public health response efforts. So again, like we saw in previous slides, cases are decreasing. Unfortunately, we do not have information available for the past 2 report weeks for the USET per capita and USET state rates, and that is due to various states having backlogs or delays in reporting COVID-19 test results, as well as the potential miscoding of county of residence. So those data points have been removed for data cleaning purposes. And this does occasionally happen, but the USET county or per capita rate that we have for the week of 215 to 222 was reported as 14.95 cases per 10,000, while the USET state rate was at, sorry about that. The USET states rate was at 14.22 cases per 10,000, and we do have the United States rate for the current report week, so that was at 9.45 cases per 10,000. So again, cases are definitely going down across the board when looking at all 3 of these data points, as well as in the USET region as a whole too. This is the last slide that I have on COVID-19 cases before moving on to vaccination data. And this visual is also sent alongside your reports as well. So we are currently looking at 14 different graphs that display the state rates over time in all USET states, as well as each individual USET state. Just a few things to make note of with this slide. You'll see that Florida is a flat line here. And that is simply due to not having the data needed for us to report on. They are reporting monthly, I believe, at this point. And so we are on a weekly schedule. And so we just simply do not have the information to report on. In general, you will notice that all of the USET states have seen decreases in cases over time. Connecticut did appear to have a small uptick in cases for this week in particular, but this is most likely attributed to backlogs and COVID-19 case surveillance reporting. But it is my hope that we can continue on this trajectory of seeing decreases and remaining at a relatively low number of cases. So I wanted to now transition a bit to some COVID-19 vaccination data. So that is what you'll be seeing on the next several slides that I have. COVID-19 vaccinations in the USET region. At this time, we are still encouraging those that are able to get vaccinated and boosted to do so, as that is still very important. Although I do feel that we have reached a time where thinking about COVID-19 as endemic is not out of the question. And so my colleague Tori will be speaking more to that later on. So definitely stay tuned to hear more about that. Overall, we are still making gradual progress with getting people vaccinated in the US, though things have slowed down greatly since from when we first started. When looking at the bar graph on this slide, you can see the progress that's been made from a week-to-week standpoint. And so looking at the percentage of population fully vaccinated by reporting facilities in the Nashville area, the United States, as well as the Indian Health Service. The bar that we have for reporting facilities in the Nashville area is based on vaccine data sent over from IHS for a total of 17 sites conducting vaccinations. So we do get that from VAMS and the IHS COVID-19 dashboard. But then the percentages for the other two bars are from CDC's COVID-19 data tracker. So for this current report week, the percentage of population fully vaccinated for the USET region was 52.8%, while the United States was at 65.1%, and then the Indian Health Service at 41.1%. And do please note that we do expect the actual percent for the Nashville area to be higher, as again, we do not have the information from all of our membership in just those 17 sites. This next graph gives us data on the percentage of population fully vaccinated, but instead now it's broken out by all of the USET states, the United States, and reporting facilities in the IHS Nashville area. So you can also see the percent increase that has occurred from week to week with this graph. When taking a look at the percentages for the individual USET states, we do see that the percentages for this week range between 50.4% and 83.4%, with 0.1 to 0.2 increases seen from the previous week for all states, aside from Rhode Island, which did have a 0.5% increase from the previous week. As I'm sure everyone has kind of experienced, vaccinations as a whole have slowed down since the rollout. And even when comparing the week-to-week percent increases we were even seeing last month compared to now, vaccinations have also slowed down. So the reports do include additional COVID-19 vaccination doses and booster doses as well. So like the last graph we saw with, we do have USET states, the United States, and reporting facilities in the IHS Nashville area displayed, except now we are looking at the percentage of population fully vaccinated that have received another dose of COVID-19 vaccine. And this does include booster and additional doses, as I mentioned. So percentages for the individual USET states range between 16.5% and 61.9%, with about 0.2 to 0.4% increases seen from the previous week for all of the states. And it does look like the percent increases we are seeing for booster doses is a little higher than the fully vaccinated. So that is good to see, since being boosted is technically being fully vaccinated. So individuals are getting boosted, maybe not at a high level, but there is still some progress there. And then very quickly, I wanted to go over this last slide with COVID-19 vaccination data. This is also a graph that we are thinking about taking out of the reports, since it has not, the numbers haven't really changed much from week to week reporting. But this bar graph does give you the percentage of delivered COVID-19 vaccination doses that have been administered. And it's broken out by the United States, USET states combined, as well as individual USET states listed. And these percentages kind of just tell us that for the current report week, there was a good job done in getting COVID-19 vaccine delivered to states, administered to the public. And so, like I said, these percentages have pretty much remained the same, with little fluctuation when referencing different report weeks. As always, please feel free to reach out to our USET Tribal Epidemiology Center team if you have any questions or concerns related to COVID-19, as well as any other public health concerns outside of that. We are always happy to assist with any technical assistance or questions that you have. And our email address is usetepi@usetinc.org if you would like to get in contact with us. I'll go ahead and take questions now. And if not, I will pass it on to my colleague.
Thank you, Amani. And I just want to take this time to say thank you so much for your continued superb reporting. I know it takes a lot, but it also takes a lot of people. So Jesse Lorenzo, Christy Duke, Taloa Berg, y'all have done a great job. So thank you.
Thank you, Brian.
Imani, this is Christy, and I echo what Brian says. I did want to just throw out there, I know we asked on the health director call yesterday, but I'll ask again today. Are these reports still useful on a weekly basis, or should we start going to monthly? Some of the responses we got on the health director's call were mixed. So what I think we're going to do is put out a poll in next week's email just to see what your tribal nation prefers, and then we can tailor the reports. But if anybody would like to chime in now, that would be great. Is weekly still useful, or would monthly be more helpful to you? And you can just put it in the chat if that's okay. And then I can turn it over. Is Tori or Dr. Brown up next?
Dr. Brown is up next.
Okay, so I'll turn it over to him if y'all can just put that in the chat. Thank you.
Do we have any more questions for Amani? I'm sorry. Do we have any more questions for Amani before we move on to Dr. Brown? Okay, well, we can go ahead and move on to Dr. Brown. Taloa, if you will pull up the PowerPoint for Dr. Brown.
Thanks, Taloa. My presentation this morning should be fairly short, I hope. If you'll go to the first slide there, Taloa. Guess what today is, everybody? It's day 731 of the pandemic. And then give you a real brief update on, the vaccines for the under 5 age group. Next slide. So today, can you believe it? Today is exactly 2 years ago that the World Health Organization declared a pandemic of COVID-19. It's hard to believe that we're still in this, but there is a lot of good news. For one thing, we're a lot better at treating it than we were at the outset. We know a whole lot more about the virus and how it behaves. The latest variant, the Omicron variant, seems to be a little less deadly than some of the other variants. So this has now evolved into a highly transmissible but somewhat less virulent form. And that's actually good news, because if it's more transmissible, that means it'll be the one that sticks around. And if it's less virulent, then less people will get really sick and die from it. Cases right now are the lowest they've been in about 8 months. We have actually three specific antivirals. There are 2 specific oral antiviral drugs we have now. And then there's the IV drug remdesivir. We have monoclonal antibodies, and we have safe and effective vaccines. So there's been a whole lot of progress in 2 years. Next slide, please. So this is just the curve over time since January of 2020, when the first cases were reported in the US. You know, we've seen waves come. The latest wave, Omicron, has dwarfed everything else. This is where we were a month ago. And if you'll go to the next slide, you can see how it has continued to drop. We are now at the lowest rate that we've had since July 19th last summer. So that's very good news, and the trend is continuing to go down. Next slide. This next slide is really the heart of my presentation today. It's the most important thing that I'm going to talk about, and that is the CDC has made some different recommendations about what interval to use with the 2 mRNA vaccines, the Pfizer-BioNTech and the Moderna vaccine. As you probably well know, the Pfizer vaccine was given in 2 doses 3 weeks apart, Moderna given in 2 doses 4 weeks apart for a primary series. There's been a change in that. So if you'll go to the next slide, I'll just sort of hit the highlights of their new recommendation. So now the recommendation is, now this is for people who haven't been vaccinated. So, you know, this isn't going to apply to a whole lot of people, because really most people who are willing to get vaccinated have been vaccinated. But if you get somebody who hasn't been vaccinated yet, the recommendation now is, if you can wait and they're under 65, give them the second dose of either Moderna or the Pfizer-BioNTech vaccine at 8 weeks after the first dose, instead of the 4 weeks for Moderna or the 3 weeks for the Pfizer-BioNTech. And that applies to people aged 12 to 64. It does not apply to the under 12s, does not apply to the over 64. This is especially true for males aged 12 to 39. Now, why is that? You probably can guess that it's because of the risk of the rare but somewhat serious condition of myocarditis and pericarditis. There are now a lot of studies from various countries, the US, Canada, the United Kingdom, the Nordic countries, Sweden, Norway, Denmark, Finland, and they've looked at giving these mRNA vaccines at longer intervals. And what these studies have consistently shown are several things. One is Moderna seems to cause myocarditis at a higher rate than Pfizer-BioNTech. That's the first takeaway. The second takeaway is that if you give the vaccine 8 weeks apart rather than 3 or 4 weeks apart, the rate of myocarditis seems to be lower. And that's been pretty consistent with every study. And this is especially true in the age group 12 to 39 male sex. So they still want to use the shorter interval for people who are moderately to severely immunocompromised, everybody who's 65 and older, or for anybody who needs rapid protection. So if there was an outbreak, let's say, a lot of community transmission going on, you might want to go ahead and go with the shorter interval for everybody. But for now, especially since the cases have dropped to a pretty low rate in most places across the country, if you get somebody in who hasn't been vaccinated and they're agreeable to being vaccinated, the mRNA vaccines are preferred over the Janssen vaccine. And if you can, especially for males 12 to 39, give it at 8 weeks between the first and second dose. All right, next slide. That's all I'm going to say about that, unless there are questions. Just wanted to, you've heard me talk about Novavax before, very high efficacy vaccine that was submitted for an emergency use authorization for age 12 and above. The FDA has still not met, and from what I can tell, they still don't have a meeting scheduled. That was as of yesterday. But hopefully this vaccine will be approved soon. It's being used in a lot of different countries right now. We're one of the sort of last to approve it. The other vaccine that's on the horizon is another protein subunit vaccine. So it's very similar to the Novavax vaccine made by the ginormous companies Sanofi and GlaxoSmithKline. It has pretty good efficacy, very high efficacy for severe disease, moderate for symptomatic. It does use an older adjuvant that has a long track record. They haven't yet submitted paperwork to the FDA, but they say they're going to pretty soon. So these will probably be available sometime this year. And for people who are afraid of new technology, they might be more willing to accept one of these vaccines. Next slide. What about the little kids? You remember last ECHO, a month ago, the FDA was supposed to meet that following Monday, and they actually canceled the meeting kind of at the last minute. I think that was probably a reasonable thing to do. The information that I have, and this is just from a source that I have at the CDC, says that the FDA probably will meet sometime in April with CDC following shortly after that. You can probably expect vaccine distribution for the age 6 months to 4 years will be happening maybe sometime in May, but all of that's pretty speculative at this point. They don't have a meeting actually scheduled. Next slide. I told you it'd be short. Any questions?
Thank you, Dr. Brown, again, for always giving us the insights that you do and breaking them down to where we can understand them.
You're very welcome.
Do we have any questions for Dr. Brown at this time?
Hi, Brian. I have a question. Dr. Brown, I've been reading several articles about the efficacy and like how the vaccine is working in the kids that are like between 5 and 11. Do you have any information about that? They're not producing a great immune response to it. Have you heard anything about that?
You're talking about children age 5 to 11?
Yes.
Or the 6 month to 4-year-old group?
The 5 to 11.
5 to 11. Yeah, I mean, initially they did have a good response. I think like every other age group, that response decreases over time. You know, it's definitely going to look different with this age group because of Omicron. You know, Omicron is able to overcome vaccine immunity much more so than the other variants were. But the good news there is the vaccines are still highly effective at protecting people against serious disease. But I don't have anything further than that. We might talk later offline. You could share those articles with me.
Okay, sounds good. Thank you.
Sure.
And if there's no further questions for Dr. Brown, we can move on to Emily Bear, who's going to give us updates on the White House plan and mask recommendations.
Thanks, Brian. You should all be able to see my screen, hopefully. Great. So I am talking about CDC Mask Recommendations, and I'm also going to be covering the new indicators that are kind of the basis for those recommendations. So a couple weeks ago, the CDC announced that they're refocusing their efforts from eliminating SARS-CoV-2 transmission to preventing medically significant illness. So what that means is previously we were just trying to stop the spread entirely, and now they're just trying to prevent serious complications and minimize burden on the healthcare system and overall just protect the most vulnerable among us. So of course, with the refocus, we need new indicators to tell us where we are in that path, those goals. So those indicators are intended to help state and local officials determine appropriate actions to be taken in the community to prevent serious illness. And like I said, they're particularly in regard to mask recommendations and other strategies. The hope is that they provide us kind of a guide for and the implementation standards for prevention strategies. So kind of when we can take our masks off, when we need to ramp up certain strategies like distancing or avoiding like group events and remasking. So that's our goal. And what we were using previously, like I said, was for preventing the spread in general. So it falls to reason that those two metrics, kind of similar to what Amani discussed, were total new cases per capita and % test positivity rate for the last 7 days. A lot of us are probably pretty familiar with this level of risk. There are 4 levels of risk defined. And you can see here, I'm not going to go through them all again, but for community transmission, the case rate was 100 or more for high transmission counties and with a 10% test positivity rate or higher. Now with this new focus, the CDC has developed new indicators, and those are called the COVID-19 Community Levels. So looking, they actually had 4 criteria for selecting community indicators. The data had to be available at the county level or allocated to the county level. The data source had to have nationwide coverage, and it had to reflect the intended focus of the indicators. It also had to be reported at least weekly or more often. So for example, we've seen like wastewater surveillance has become more and more widely used, and it's been a really good early indicator of imminent waves. And it's also been a good indicator of when we've hit a peak in a wave as well. However, it's pretty limited in our capacity for surveillance at the moment. So it's definitely not nationwide. It's kind of limited to like big cities like Boston and public health municipalities that have like a lot of infrastructure. So that wouldn't be, even though it's a good indicator for spread, it's not necessarily a good indicator for community levels as determined by the CDC. So with that, all these criteria in mind, they arrived at these two metrics for the community levels: COVID-19 hospital admissions per capita in the past 7 days, and the percent of inpatient beds occupied by COVID-19 patients over the last 7 days. So this is just a look at those community levels and those new categories of risk. And you can see they did actually include case rate here per capita, which is good to see, because I know a few of us weren't sure if that was going to be included, but they have stratified it by 200 or fewer cases as low, medium, or high risk, and then 200 or more would automatically put you into medium or high risk county level. This is a look at the previous community transmission levels by county versus the new community levels. Sorry that I didn't name them, but the names are a little bit confusing. So the community transmission levels are on the right, and the community levels, COVID-19 community levels, are on the left. And you can see they're both polled on March 8th as far as data, but the community levels were only updated as far back as March 3rd. So they're not exact comparison, but pretty close. And you can see that in the community transmission counties, there's quite a few more counties that fall into moderate, substantial, and high risk categories. So that would be places where you would be previously expected to be masking and taking other precautions, versus the community levels where the vast majority of counties now fall into low and medium risk categories. So you wouldn't well, I'll go over the recommendations in a minute, but you wouldn't necessarily need to be masking and all that, or at least you wouldn't be recommended to officially. But yeah, only 15% of counties are now considered at a high level of risk according to the COVID-19 community levels, which is kind of unevenly dispersed, but you can see there's some pockets in the eastern region. So I don't have time to go over how the CDC developed these indicators, but I can just put a couple considerations here for those of us who are using them and want to understand the statistics behind them. So this is one concern I've seen raised, is that there's technically a discrepancy between the way the numerator and denominator for hospital case rates is determined, since the hospital admissions and percent of ICU beds occupied is based on where people are admitted, and it's actually I think it's based on a HRSA region. So it's kind of allocated to a county. It doesn't necessarily reflect, what's happening in a hospital in your county. Like if you have one hospital that has 2 COVID patients, that's not exactly what they're saying, even though your resident population per county is used as the denominator. It's probably not a huge concern, but just something to take note of. Then the substantiation for the reason that the 200 cases per capita was chosen as the cutoff hasn't been provided to us. So that is something else I just wanted to point out, that previously, based on case rate, anything above 100 cases, and that's that orange line on the graph, was considered a high-risk county. And now anything above the green line is considered medium or high risk, and that only depends on your, obviously, your hospital admission rate and inpatient capacity. So just an example of the change. And now talking about recommendations on new indicators. This is Primarily, they provided individual and household level preventive behaviors, but there are some community level strategies for people operating at that level. So at low and medium levels, you are not recommended to mask necessarily unless you are at risk, and you can follow the established recommendations for isolation and quarantine and seek testing if you're exposed or symptomatic. And of course, they always recommend staying up to date with COVID-19 vaccines and boosters. For medium and high levels, again, you're still not required or recommended to mask indoors unless you are immunocompromised or at high risk. Of course, if you are responsible for someone, like children who can't get vaccinated or other vulnerable people in your family or something who are at high risk, you might want to consider, I encourage masking and considering self-testing before contact. And then at high risk, you are recommended to wear mask indoors, and that is regardless of vaccination status and in schools. However, at the community level, there's not really a call for mask mandates in those settings. There's just a recommendation to implement masking indoors in populations at high risk. So to sum up, there's new indicators that are guiding the COVID prevention strategies that we put into place that the CDC recently developed. And they are redeveloped because our focus has changed to prevent medically significant illness rather than to prevent the spread of COVID. I wanted to note that this doesn't apply to healthcare workers, nursing homes, long-term care facilities. I believe that also includes prisons and places like shelters. They're still recommended to follow guidance for those specific locations, and those are based on community transmission guidelines still. The last note for that is that these are new indicators, so we will see how they work with the next wave, assuming there is one. And I guess the only thing to take note of is the concern that there might not be enough lead time to implement changes, since these are based on hospitalizations, and often at that point it's a little too late to implement stuff like masking, but it's always helpful. So we'll see how, we will have to evaluate how they work. And tying into all this is the new White House COVID-19 response plan that was released last week. The National COVID-19 Preparedness Plan, it's focused on 4 key goals: prevention and treatment of COVID, preparation for new variants, prevention of economic and educational shutdowns, and to continue efforts towards global vaccination. I won't go through the whole plan as we're working on an alert, and it's also available linked in the slides and on the White House website. Primarily, these are the key objectives of Goal 1. So we're trying to increase our vaccination capacity. We're trying to increase the supply of Paxlovid, which is the Pfizer oral antiviral that is very protective against severe disease. And kind of a really interesting initiative is a nationwide test to treat program. So that would provide access to treatment, presumably, I believe it's just Paxlovid immediately if they test positive, if someone tests positive for COVID-19. So you can kind of go test. If you're at high risk and you need treatment, you will be able to get it immediately, which would be great. And I believe it's expected to launch in March. Well, it is expected to launch in March, but I have not seen a date. I'm aware that it's March though, so we will have to see when that happens. And of course, be on the lookout, because as the TAC, we'll communicate that as soon as we can. So for goal 2, some of the key objectives are pretty much just ramping up our collection and sequencing of COVID-19 data. So talking about stuff like wastewater surveillance, we're trying to expand our capacity to detect new variants and determine their level of concern, so we can respond a lot more rapidly than we have been able to in the past. And also adding home tests, antivirals, and masks to the national stockpile. Finally, goal 3 is focusing on giving schools and businesses the tools they need for COVID-19 prevention. And I'm happy to see that involves improvements to indoor ventilation and air filtration, which is definitely an area that we need to work on still. And then goal 4 is focused on achieving global vaccine equity. So we will continue, the US will continue distributing doses to countries in needs, and also contributing oxygen, just solving the oxygen crisis and making emergency supplies more widely available. So there are a lot more objectives to this in the main White House plan. Like I said, it's linked in the slides, and we'll have an alert coming out that sums all of this up as well. But that is all I had to go over today. So thank you, and I'm happy to take any questions.
Thank you, Emily, for a great presentation. Do we have any questions for Emily before we move on? If not, we can move on to Tori Reeves, and she's going to be giving us a presentation on moving towards endemic. So if Taloa, you got it. Okay. And Tori, you're on.
Thank you, Brian. Great presentation, Emily, and it just goes and leads right into my presentation. And I know for the last 2 years, everyone has talked about COVID, and we're kind of getting burned out as we're looking to move to endemic. So let's see, are we there yet or not quite there? So everyone, I'm sure, is an expert on what a pandemic is. You know, basically, we're looking at rapid, widespread disease, exponentially rising cases, not just in one particular area. As we've seen, COVID has essentially touched all of the continents, and everywhere. There are no places that are left untouched by COVID. Some were impacted more severely than others, including the United States, but basically, like, that's what a pandemic is. So endemic, once a virus becomes endemic, it's more consistent, or it's more, we kind of know what it's going to do. They're always around, or they may not always be around all year round, or they may come seasonal, such as like influenza. We do see influenza that comes in the wintertime. All respiratory viruses particularly don't follow the same pattern as flu, something such as the rhinovirus that circulates all year round, but it doesn't cause as much disruptions as something like Ebola, an Ebola outbreak, or what we see with the influenza virus that comes typically between late August until like March, May, just kind of depending on where you are. So next slide, please. So what we know right now is we don't know if there's another variant on the horizon. COVID has shown that it is a fan of evolution, and mutations have occurred pretty rapidly and quite significantly, as we've seen with Delta and Omicron. So we don't have a predictable pattern of disease. And as we've seen, numbers don't lie. Just as we think that we are kind of calming down, and then we'll see a peak with the new variant, as we've seen with Omicron. It came and it literally penetrated all of the immunity that had been already built up through previous infections, through the original COVID virus, as well as from Delta and all of the vaccines. And it just went around and just kind of reinfected everyone again. As of today, when I pull this information and the resources, hospitalizations and deaths are still not stabilized. And this was as of March 7th. I have a little bit more information about that later on. And we want to highlight that with endemic, it's expected that rates usually don't increase or decrease significantly. They're kind of like stable. You may see peaks here and there, As we said, with flu season, you may have like a high level of flu cases during particular months, particularly like in those like January, February time, or around holiday season. But with endemic, we want to especially highlight that it does not mean that the virus is less contagious, less infectious, or less deadly. All of those things still remain as the pandemic goes to endemic, but it just means that we'll kind of know what to expect a little bit more from there. And even with endemic, we will still have outbreaks and waves of infections that will occur, as we don't know right now if it'll be seasonal or if it'll just kind of exist all year round. We don't know that. Endemicity of any type of disease is typically much better understood retrospectively. And we've only been in this for 2 years and we have not moved outside of the pandemic, so we don't really know what that's going to look like. We do know that there will be a new normal. You know, masks will still be required at certain places. Testing is going to be ongoing, and surveillance is very, very important. Next slide, please. So as of today, there are no variants of concern, which is a really good thing, but very positive. You know, maybe mutations have kind of taken a break there on holiday or something. So a big part of being able to move from pandemic to endemic is Sentinel surveillance. Sentinel surveillance allows for like an organization or a school or a state to randomly test a percentage of the population. And in this case, it could be like a tribal nation staff or citizens, even school age children if you have a school or a daycare. And this is to allow you to monitor and protect the workplace, environment, school, just the community from COVID-19 and decrease the likelihood of outbreaks, trying to get ahead of those outbreaks. So an example of Sentinel surveillance could be testing like every 10th person that comes into the tribal health clinic each day, or it could be testing every 5th child that comes into the classroom, of course, with permission from the parents. And then another example that we'll talk about a little later is wastewater sampling as well, which is I'm a big fan of, but we'll talk about it a little bit later. Next slide, please. So a little more on Sentinel testing. So what you would do is start by identifying like which populations you want to engage in. Of course, we just kind of said tribal governments, facilities, schools, health clinics, or you could also do it throughout the community, you know, of course, with community buy-in. You want to determine what your desired monthly testing levels would be or the frequency in which you would conduct them. These are all more so like your protocols that you will put in place to make sure that your program is successful so that you can evaluate it to make sure evaluate to see if there's anything you want to change, and then to make sure you are able to keep track of everything. So determine a test level requires that looking at a couple of different factors. Of course, you want to look at what is the current status of COVID-19 with the community, the vulnerability of the populations that you're testing. If you're looking at testing elders versus testing children, children are probably going to be a little bit less compliant and willing to be tested kind of frequently. You know, it is very uncomfortable to have that NP swab in your nose. And then you also want to look at the other measures that are also prevention measures, you know, it's like social distancing and wearing masks indoors or in poor ventilation areas as well, as Emily mentioned in her presentation. Next slide, please. So as we continue with Sentinel testing, you want to determine how your testing will occur. Of course, they can be like a physician's order. You know, your physician is directing you to test a certain population or look at a certain demographics, if they're more likely to be infected or just kind of like asymptomatic players, like school-age children. How will the specimens be collected? Are you going to do like the throat swab? Are you going to do the NP swab in the nose? How will the specimens be processed? Are they going to be rapid? Are you going to do some PCR testing? How all of that be handled? Who will be in charge of handling that, as well as the reporting and notification of results? Because it's kind of pointless if you're just collecting it and if you're having positive results, but they're not being communicated back to the person or persons that tested positive. And then what are you going to do about those cases if you do identify positive cases? So that's where contact tracing of those positive individuals come in. Are you going to require quarantining? Are you going to require isolation, medication? So you have to determine like what this whole process will look like, and so that it can best benefit your community. Okay, next slide. So as previously mentioned, this is something that's actually been going on throughout the entire pandemic, and actually a little bit prior to the pandemic being a pandemic, is wastewater testing. So here, this was a study that was conducted, and it was in Brazil, that they were detecting SARS or COVID-19 in the sewage samples. That was a total of 41 days before the declaration of COVID-19 cases in 2019. So that really says like a lot. It really says how significant wastewater treatment is. And I know most people just probably think it's just like, fecal matter and other gross things, which it is, but those gross things in fecal matter has the potential to prevent an outbreak. So in this particular study, they use it, of course, to anticipate COVID-19 outbreaks, to evaluate the impact of control measures that were in place, as well as estimate the burden of shedders, including those pre-symptomatic people, because we know that you're most infectious 2 days prior to you start showing symptoms, as well as patients that don't ever show symptoms, the asymptomatic patients, symptomatic patients, and undiagnosed cases. So those people who never go to the doctors and just everything is a cold, or they just kind of want to ignore it. Even if they're ignoring that, the virus still can be detected in their fecal samples. Next slide, please. So with this study, they used the model, the Susceptible Exposed Infectious Removed SEER model, to estimate the total number of shedders that showed a high proportion of asymptomatic infected individuals. So we've seen throughout the pandemic, a lot of times people don't show symptoms for COVID, but they're infecting the people around them. Or they just randomly get a test and then they test positive from that. So the caveat or the big part of this is, Sentinel surveillance. It's of specific sewers, like we're going to say like hotspots, or again, a part of that Sentinel surveillance where you want to test certain populations are essential to help locate COVID-19 hotspots and to conduct PCR testing among populations during the peak of pandemic. So that is one time when it was used, also as well as trying to identify areas that were having hotspots or predicting those hotspots as well. So it was really great. And I have linked information about this study if you're interested in the references at the end of the presentation, if you want more information about it. Next slide, please. So the question of the day that everyone wants to know, are we there to go to endemic? And it's like, we're almost there, not quite. Because when we think about the pandemic, it spans, as we said, multiple continents, areas, countries, and things like that. And most people just are thinking solely in the United States. So as of right now, there are 250 million people in the United States that has at least one COVID-19 shot, which represents about 76% of the country. And 81% of vaccine eligible people, which is ages 5 and up. Excuse me. However, across the world, more than 60% of people have been vaccinated on every continent, which is great. But they have the exception of Africa, which is only at about 13% of everyone receiving their fully vaccination status. We are still seeing high cases among the globe. Currently right now, like Hong Kong is in a new outbreak. And in New Zealand, their daily cases are currently going back up. So we do have people that are vaccinated. We're talking about that, which is going to be the biggest push to reducing the pandemic and being able to move to being endemic. and making sure that people are boosted as well. So there are some additional numbers here and percentages that you can, if you're interested in that kind of thing like we are. Next slide, please. So the story is not yet, but one day, and I won't even say one day soon, but hopefully, we'll be there. But the reality is COVID-19 is not going to go anywhere. It's here to stay, just like the flu and all the other viruses that we encounter. The vaccine is also here to stay. As Dr. Brown has highlighted, there are several other vaccines that are in the works that will come out. And endemic, again, does not mean less infectious or less deadly. We don't know what COVID-19 or SARS-CoV is going to do. As we said, the endemicity of viruses is best known retrospectively, which we haven't done that just yet. But there are two important factors that we should look at as we're looking to move to endemicity, which is the frequency and the severity of outbreaks as they come up. These will delineate the disruption that are caused by COVID going forward and kind of give us an idea now that cases are going down, and future outbreaks that may happen are going to be dependent upon the population immunity and the mutations in the virus. COVID-19 has shown that it has the ability to produce some significant mutations in the virus, shown in Omicron, how it lost some of the spikes and changed the S proteins that were in there, which evaded the immunity of all those people who had received the vaccine or that were previously infected with the original COVID or Delta as well. So because we don't know what or how the virus will actually continue to act, maybe it has lost the ability to produce such significant variant changes, or maybe has not. We don't know at this time. So we're just kind of watching it and seeing if it's able to disrupt some more communities that have been that have immunity. But we're gonna hope for that it has lost its spunk. But until then, we have the vaccines, we have current vaccines, new vaccines coming. We have masks that do help prevent infections with other measures, the supportive care that you get when you have COVID, as well as testing daily or as frequently as needed in your community. Next slide, please. And thank you. Are there any questions? And the next slide after this is, of course, if you have questions, please reach out to us, as well as the resources that were used for this slide and the data about this study as well. Thank you.
Thank you, Tori. And if we have any questions for Tori, please ask them now. Great presentation, by the way. It's very enlightening. Emily, do you have any further comments about trainings that Emily Bear?
Thanks, Brian. Yeah, I just wanted to let everyone know that the TAC is putting on 2 upcoming trainings on different COVID-19 strategies. So one that is scheduled for April is a 3-part training series for vaccine uptake. So we will be training people on motivational interviewing, which is a psychological behavior change tool. So it's essentially going to be teaching community members how to talk to like friends and family to kind of tap into their intrinsic motivation to help like protect their communities, protect themselves, and get vaccinated. So that one is in April, and I'm going to put the link here if anyone would like to register.
And it is only open to USET membership.
Thank you, Brian. It is. And if you would like to share that among your community, we would really appreciate it, as it's definitely geared towards just community members and not like clinical staff, like some of us who are already doing this work every day. And the other training is also tentatively scheduled for April. I will be able to, you'll see an alert once we put that out, but that one will be for air quality, again, for tribal staff, specifically for people who are in a position to be like maintaining buildings, school administrators, people like that. And that is going to be focused on ventilation and filtration. And we're doing that in partnership with the Institute for Tribal Environmental Professionals. So they'll be coming in to do that. That's another 3-part training. And then we will hopefully be able to provide monitors and air quality other tools to people who attend. And yeah, like I said, I'll share that information as soon as I can.
Thank you,
Thanks,
Emily.
everyone. And let me please, like everyone said, just email the USET EPI people or email me if you have any questions about the trainings or you need materials to share with your community.
Great. Thank you, Emily. If there's any further questions, please ask them in the chat or unmute yourself and ask. Just a reminder to fill out the survey that Emily has posted in the chat a couple times. You'll post it again for those that have not seen it. It gives us some great feedback on how we're doing and what we need to work on or what we need to focus on in the future echoes. And just a reminder as well, we do have some additional echoes that are coming up. We have the hepatitis C echo that occurs monthly, second Monday of every month, and the Reclaiming Native Psychological Brilliance series that occurs the 4th Tuesday of every month. Yes, so if there's no further questions, we can go ahead and adjourn. Y'all have a great rest of your Friday and happy weekend. And yes, thank you all.